Now we're going to look at assessing and managing the circulation over the next few minutes. Once again, always remember danger, response, send for help, assess and manage the airway until the patient has a patent airway, assess and manage the breathing until you're happy with the breathing, and then you can finally move on to assess and manage circulation. Exposure of the patient is key when assessing circulation. You're looking for the general appearance, colour, and any signs of trauma with the patient. Obviously, signs of bleeding and hypovolemia can be very easy to spot, but then again, there are certain cases of surgery, obstetrics, gynecology, where there can be hemorrhage, but it may not immediately be visible. Expose the patient, general appearance, attach a SATS monitor for a pulse, get a blood pressure, and get a central capillary refill where you press and hold on the sternum for 5 seconds and then release to see how quickly the circulation returns from underneath your finger. The blanching should disappear within 2 seconds. Anything over 3 seconds is a sign of shock. Attach a 3-lead ECG monitor and see what the heart trace is doing. At this stage you might want to try for intravenous access. You should attempt 2 wide-bore IV cannulas in both antecubital fossas, typically 14 or 16 gauge. Every time you put an IV in, you must take something out, so take a blood sample for blood count, electrolytes, coagulation, bedside glucose, and a cross-match, and any other bloods you think may be appropriate. If you fail 2 IV attempts, you should move on and try an interossi. This is a very sensible and easy way of getting good, fast access. You're unable to take blood from it, but you are able to give fluids and you are able to give medication. What you see in the diagram at the bottom is an easy IO. That makes placing an intraosseous needle very easy, and we'll get a chance to practice this on the practical day. It's very useful for children and in adults, and the best site for intraosseous access is on the proximal aspect of the tibia, on the tibial plateau, on the medial aspect. Clean the skin, and without local anaesthetic, go 90 degrees to the skin, straight into the bone. We'll get a chance to practice this on the day. Okay, what we're also going to have a look at in this lecture is shock, and ahead of you are 4 types of shock that we commonly see in emergency medicine. There's anaphylactic shock, hypovolemic shock, septic shock, and cardiogenic shock. Shock means that there is inadequate tissue perfusion and oxygenation, and the body cannot meet its metabolic demands within its tissues. Think of shock as a failure of the pump, which would be cardiogenic shock, a failure of the circuit and leaky circuit, which would be anaphylactic or septic shock, or a reduction in the volume of fluid which is being pumped around, which would be hypovolemic shock. When we have a look at this slide, it gives you some examples of shock and how you can identify them. In anaphylaxis, there may or may not be a history. The patient will be pale and may have a rash. They may have a tachycardia. They very certainly will have hypotension, and they'll have reduced capillary refill. The treatment for that is good airway management and adrenaline early, and we'll have more slides on anaphylaxis later on. Hypovolemic shock, the patient's typically pale, and as described previously, there may or may not be signs of hemorrhage. There will be a tachycardia, a hypotension, and reduced capillary refill. The treatment is to stem the flow of the bleeding, resuscitate with fluids, and give early blood products. In septic shock, the patient may appear normal or may be flushed or pale. They may be tachycardic, hypotensive, but have increased capillary refill due to vasodilatation within the capillaries of the skin. The treatment here is good fluid resuscitation and antibiotics. Finally, cardiogenic shock. The patient will be pale, sweaty, clammy, diaphoretic. The pulse may be up or down. The blood pressure certainly will be low and reduced capillary refill. Cardiogenic shock carries a very poor prognosis with up to 30% mortality and is often caused by myocardial infarctions or other forms of cardiomyopathy. inotropes, cardiac pacing, GTN, diuretics are some of the ways in which you can manage a patient that's in cardiogenic shock. Okay, just a few words on fluid resuscitation. You don't need to give fluids just because you can. You need to give fluids for a reason, and that's typically when the patient is shocked in ways that we've just been discussing. 20 milligrams per kilogram of normal saline is the fluid bolus of choice during a resuscitation, and that's obviously tailored to the size of the person. So for a 100 kilo male, you will need 20 milligrams per kilogram, so you will need 2 liters of normal saline stat. The fluid bolus can be repeated once if there's poor response, but if you suspect that the cause of shock is bleeding, you may want to consider giving blood products early. Repeated fluid boluses in hemorrhage will cause hypothermia, coagulopathy, and an acidosis, ultimately affecting the patient's ability to clot and can make their shock worse. So always think about giving fluids for a reason at 20 milligrams per kilogram and consider blood early in signs of hemorrhage. Thank you.